Our next speaker will give us the provider perspective on health information technology. Dr. Gregg Stefanik is a family medicine specialist. He's been practicing in Alma, Michigan since 1991. He's employed by Covenant Healthcare, headquartered in Saginaw, and he led his practice, Gratiot Family Practice, along its way in becoming a patient-centered medical home. Dr. Stefanik strongly believes in an empowered, proactive, patient-backed system supporting the patient and their efforts. Besides serving his patients, Dr. Stefanik also serves as the medical director of the Gratiot County Medical Physicians Organization. He is president of the Great Lakes Organized System of Care, and he is also a member of both the Michigan and American Osteopathic Association. Please join me in welcoming Dr. Stefanik.
Love is a burning thing, and it leaves a fire ring. I fell into the burning ring of fire. I can't get that song out of my head for some reason. I can't figure out why that is. I scared you too, didn't I? You thought I was going to sing the whole thing. That's not going to happen. Thank you so much for being here today. I am a family physician. I've been at Alma for 27 years now. I was an independent physician for 20 of those years. In the last 7, I'm employed by Covenant Healthcare from Saginaw. I have a disclosure to make. It's a financial disclosure. I am part of, and I have made money from, this current system that incentivizes treating sickness over valuing health. I believe in personal responsibility for one's own health, and that we need to spend as much time in our efforts to try to keep the healthy as we do in trying to help the sickest among us. I also feel a responsibility to be part of the solution, and that's why I'm excited to be talking here today about HIT and how it affects my daily practice. I believe that providers do need to embrace HIT, as it ultimately allows for better patient care. But I also believe to make sure that the technology solutions we come up with first address the problems we face and not interfere with the relationships that we nurture. The purpose of HIT is to share information and connect us in a meaningful way to improve health. But what does it mean, really, to be healthy? Most definitions of health go beyond a sound physical mind and body, but also include the concept of well-being, which is not just how you feel about your health, but also about your life. Evidence shows that people with higher levels of well-being are healthier. So for health information technology to be truly about improving health, it also must consider how it looks after our well-being. And that means not just for our patients, but the well-being for our providers too. 2 years ago yesterday, a 20-year-old named Quentin Greiner was driving to the airport early Sunday morning to attend a university-sponsored leadership conference in Montana. He has a passion for working with kids, was attending Spring Arbor University, studying urban ministry. He was a captain of the Cougars track team, worked as a counselor, and his coach said that Quentin was a great man of faith and a leader on and off the track. He had not been drinking that morning, but the driver who swerved across the yellow line and hit him head on was. The only unfortunate thing was that it was determined that Quentin had died instantly because his body was burned up beyond recognition. Quentin was a patient of mine, and my office was shocked when we heard this news. I remember calling the father and leaving a voice message that if there's anything I could do, anything, but what could I do? Our staff does send around a card to every person in our office who passes away to their family, signifying that we care. And those cards mean more than we ever realized. We get occasionally notes back saying how important they were. But how do you handle that situation? What do you do? On July 15th, about 6 weeks after the parents' worst nightmare, Bill, Quentin's father, called the office, stating he was out of town in Myrtle Beach, but requesting a refill on his antidepressant medication that he had taken in the past, and sent to a pharmacy down there. It was Walgreens drugstore number 06877. My EMR told me that. I got the message at 2:16 in the afternoon, and at 2:21 p.m., I responded to my nurse, Amy, that I will give him a 3-month supply, but I want to see him within the next 3 months to see how he's doing. I figured he was taking a much-needed break away and getting away, and he was there to collect himself. I wasn't going to ask him to come in the office for a prescription, and I wasn't going to tell him to go to a walking clinic down there to give him a refill. The prescription was electronically prescribed at 3:40 p.m., by Amy, and at 5:05 p.m., Bill called back, said he got the prescription, got the message, he'll schedule an appointment and come in and talk about his problem when he got back in town. So before EMR, the interaction might have gone like this. The message would have come up to the front desk, and the receptionist would have taken the message, she'd have put it in a stack of charts to be pulled. The chart puller would have to find the chart, which wasn't an easy feat all the time. Sometimes it was in the back of my partner's car. Since then she would have to attach it to the chart, put it on my desk with the other messages and charts. I might have gotten to it by the end of the day. Amy probably would have been gone. We might have been able to call it the next day to the out-of-town pharmacy. How long would this whole process would have taken in a highly performing paper office? I don't think it would have taken within the 3 hours that we got the prescription that Bill needed. And I share this story for several reasons. The efficiency at which the request was dealt with. Within 3 hours, he had his prescription in his hand. The way the EMR enabled this efficiency. Maybe I was able to help in some small way. The way paper charts were really pretty cumbersome back those days. And that electronic prescribing is truly one of the technologies that relieves the burden on us in a much more efficient way of the and so important job of tracking our patients' medications. Now, before you get the mistaken idea that we are in love with our EMRs, the EMR is the poster child for physician angst these days and considered one of the leading causes of physician burnout. It probably wouldn't be useful to go into all the ways that I don't like the EMR, so I really won't do it. I mean, to spend time talking about how it's estimated that I spend 52 hours a year just putting in my password, I mean, that probably wouldn't be very productive to tell you that. Or that for every hour that doctors spend with patients, we take 2 more hours to chart work afterwards. And even when we're with the patients, 37% of the time, we're still on the EMR. Or that because of this, I can't see as many patients. Or the computer-generated notes I get from specialists that are 8 pages long. And what I really need to know is buried in paragraph 7 on page 3. That's all I really need to know from that interaction. I don't think it'd be useful to talk about this and complain about this. Or that the alert fatigue that we get. The alerts, we ignore them 50 to 100% of the time. Or that they were designed for billing and not for patient care. And that the MyChart messages, the patient portal messages we get, sometimes they're there, sometimes they're not. Sometimes they're useful, I wouldn't dream about complaining about this stuff because it just wouldn't be useful or you'd get used to your time. And then once I start complaining about that stuff, I'd probably start complaining about the forms I have to sign and the letters from prior authorizations and from insurance companies and the opioid legislations. You know how many maps I've run in the last 2 days that have been totally useless to my patient care? I wouldn't go into all that stuff because it wouldn't be useful to spend the time doing that. However, there are benefits to EMR, quite a few. One example I just showed you. It does track data over time. It identifies patients that need preventive screenings and services. The function called Care Everywhere in my Epic platform really does allow me to see tests that are done at other hospital systems. I can see them in real time, right there on my screen. It's very valuable information. I act on information all the time. My records are readable now, which before I couldn't say that. And then we have actionable data from the EMRs. We're definitely more efficient when it comes to being able to process patients' requests. But I think the biggest benefit of the EMR, it enhances the doctor-patient relationship by allowing the patient access to their own information, which allows them to take ownership of their health. Interestingly, there's still a lot of patients who don't want the access. I don't quite understand that. I actually think I read something once that the most common age group for people to use electronic records was the 60 to 70-year-olds. Young people, millennials, sometimes don't want to be involved in this, and I don't quite understand that, but there are still many who do. But what is for sure is that EMR has changed the way we practice medicine, but also the way we feel about how we practice medicine. And there are those that long to go back to patient charts still to this day. One thing that helps me tremendously in dealing with the electronic medical record is the fact that I do use, people know the term scribes, but they're much more than scribes. We call it team care, where my nurses go with me. I have an MA and an LPN in the room and help me transcribe the visit. But it's not just that they're in transcribing the visit. They're an integral part of the care. Not only do they record the visit, but they're already in the room preparing the chart, making sure their immunization's up to date, asking about their preventive screenings. And in the room, they remind me, hey doc, this patient has diabetes and they're not on a cholesterol medication, should they be? And they spend time counseling, interjecting thoughts. Initially, patients were a little bit leery about that, but I think they really like it because they understand how this team of people is caring for them. And they feel that. And so it really has been just a blessing for me. I don't really know how people with EMRs nowadays deal without this kind of enabling help.
They say one of the biggest keys to happiness in life is meaningful work with people who care. My team and I have meaningful work, and we care, and our patients feel that, and it's better for our patients. I am fortunate to be able to teach medical students. One of the many benefits of this is that I'm aware now of some of the many things I take for granted. One day, AJ, my student at the time, we're seeing Becky, a 25-year-old for depression. We listened to her story. We decided that a medication was appropriate for her, carefully discussed the side effects. We asked her in 2 weeks to send me a message through my patient portal to let me know how she was doing. After she left, AJ pointed out something I hadn't seen. He said he felt like the visit didn't end, that it was ongoing, and that she had access to me, and that she was going to respond to me. And he said that really, I think was really neat, and that felt good. And I never really took that, I never really thought about that. But that's kind of what we want with the current, and we have the ability with our current technology to make these visits and these interactions ongoing. I believe that it's not my responsibility to take care of my patients. And if that's the case, then the best thing I can do is to be available to support them in their efforts to take care of themselves. I frequently receive in my chart and email messages. I also give my patients my cell phone number. I rarely get called on my cell phone. I do get plenty of email messages, the MyChart messages, and I do occasionally get texts from my patients. I think this enhanced access and willingness to be accessible is not only vital, but my responsibility. When I was in medical school, I learned about the 3 A's of being a good physician. Number 1, you had to be available. Number 2, you had to be affable. And number 3, you had to have good ability. And the importance was in that order. I believe that today. And I've added 2 A's since then. I think we need to allow patients to take care of themselves, because I think a lot of times we haven't given them permission to do that. And I think we need to assist them in their efforts. So the 5 A's of being a good physician. I get anywhere between 2 and 20 messages a day. I find it very useful. My messages come right to me because I've made that a priority. Other providers have them answered by our staff, and they go into a pool. When I started emailing with patients many years ago, probably 10 years ago, one of my colleagues said, "Oh, great, another way patients can get a hold of me." And it's kind of funny because we're so used to like this barrier existing between our patients and I, why? Why is that? It takes time, sure it does, but people really like it and they feel cared for. Not too long ago, our time was spent in the hospital. Every time I received that number for the emergency room that someone was being admitted, it was at least an hour of my day gone. Sometimes it takes me just minutes to answer these messages. How many of you in this room have access to your physician in that way? A fair amount. How does that make you feel? A patient once said to me that she would never call me on her cell phone, on my cell phone, but just knowing that she could make her feel like I cared. Care leads to trust, and trust gives you the ability to influence. And that's what we want with our patients, the ability to influence. This messaging capability may be the simplest technology we have, but I believe it's the most powerful and maybe the most important. Many years ago, it was a Monday night, I went to the hospital to see Janet. Janet was 88 years old, and she was dying from ovarian cancer. I remember telling her 2 years ago, when she was first diagnosed, that she didn't have to seek treatment, that it could do more harm than good. Not only did she think this was not a good idea, she actually was kind of insulted that I would, in her mind, give up on her so easily. She did well for about a year, but eventually she succumbed to the cancer. She did have significant side effects from the treatment, and honestly, I don't know whether the treatment benefited her or not. But it was her decision, and therefore it was the right choice. The only reason I knew she was in the hospital that night was because of an admission, discharge, and transfer summary. We use the ADT system all the time. It's one of the most useful technologies, and one of the features, it gives us actionable information on discharges. We reconcile medications, we answer questions, we anticipate needs, and many times no follow-up visit had been scheduled. It's useful to know this direct information from these notifications, but also just knowing which patients of ours are asking the system is important too, so we do know who the frequent flyers are. And we do believe the system does reduce admissions and ER visits. It had been a long time since I had seen Janet because she had been seeing other physicians being treated for her cancer. But something told me I needed to go see her that night. It had been months since I even set foot in the hospital. I was able to talk to her nurse before I went in her room, and she told me that her condition had worsened, that all treatment was now being withheld. She'd agreed to go on to hospice, and she was being discharged to the nursing home the next day. I remember walking to the room, Janet immediately looked up, and the first thing she said was, "Well, you were right, Doc." I sat at the edge of her bed, and I said, "What do you mean, Janet?" She said, "Well, I probably shouldn't have taken the treatment because I didn't beat this cancer. It's got me." I said, "No, Janet, it was the right decision. I think it bought you some good quality time, and that was your decision." We talked for a while. I can't remember exactly what we talked about. We talked about life. We talked about death. I asked her if she was afraid of dying, and she said, no, she wasn't. I think she was ready. She said, "I don't really want to go to the nursing home, though. I just really don't." So I don't know how long I was there. I got up, I left her, I kissed her on the forehead, and I walked out. And in the hallway was her son, Rob. He was sitting there. And we talked a little bit about what we had shared. And I asked him, I said, "Have you told your mom that's okay for her to go?" And he said, "No, I really haven't." I said, "Well, you might want to think doing it." So I left. The next morning, I found out she died that night. I don't know if me going there made a difference, but I suspect it did. I'm sure many of you had similar experiences, and it doesn't take a physician to be in a relationship with someone in this way. I do know when her husband came in months later, it made a difference to him. And every time I've seen him since, he said he was so grateful that I went and talked to her that night. I never thought of helping people during the last stages of life would be so rewarding as it is. But I think I understand now, as I was preparing for this talk. It became more clear. It's a powerful relationship experience. And it's those relationships that energize our souls. I think this does illustrate the importance of the doctor-patient relationship. Research is ongoing as to how to value the doctor-patient relationship. Currently, value in healthcare is defined as quality over cost. What if the real value in healthcare is in the doctor-patient relationship? What if both doctors and patients were after the same thing, not just value, but meaning? Before technology and the advances of medicine, physicians better understood their caring role and coped with the stresses of the role through a deeply personal, reciprocal relationship with their patients. That caring relationship has been lost for many physicians in the current system of fragmented, rushed, dysfunctional, digitalized, corporatized, and costly medical care. A system that prizes efficiency over relationships, profits over common good, and volume over value. All I did that night was care, yet it was deeply soul-satisfying. Is the secret to physician wellness and burnout? Is the secret is caring for the patient? Is that the antidote? On a recent Tuesday in May, I received a call from a caring orthopedic surgeon informing me that a patient of mine, Sandra, that he'd been seeing for hip pain, appeared to have a tumor in her bone, most likely a cancer coming from somewhere else. Sandra's a long-standing patient of mine who lives in Mackinac City. She's a 2-hour and 45-minute drive from my office, but she still has roots in the city, in the area, and plus we have a caring, trusting relationship. Now, I know this story is hard to believe because I did say caring orthopedic surgeon, but they are out there. They are out there, really. This information was disturbing to me on many different counts, not the least of which that her husband was currently being treated for metastatic pancreatic cancer. And these are patients I've seen for years and years. For Sandra, it was not obvious where the tumor was, and further testing was recommended, and they recommended they do a CAT scan of her abdomen and pelvis to see if it was possibly coming from there. And that was scheduled for the following Thursday. I received this call around lunchtime on that Tuesday, and so I was able to call Sandra. The surgeon had just called her. And I said, "Sandra, I'm so sorry this is happening to you. I'm aware of what's going on." And that's all I did. We talked just a little bit. Patients react to bad news in different ways. You have the stoic farmer, and all they want to know is when they can get back in the field. And then you have other patients who have the funeral home on speed dial and just knew this was going to happen someday and waiting for it to fall on them. Sandra was more like the farmer, and it was hard, but she didn't panic. Later that day, I received an email from her daughter, who's also been a long-standing patient of mine. She said, "Thank you for calling Mom, as our family is still trying to process the news. Any recommendations or suggestions, we will take anything. This is very heartbreaking for all of us. She has been our support and anchor through everything Dad has been through." And that was about 5 o'clock in the afternoon. About an hour later, I emailed her back, and I said I was shocked and so disheartened to get the call today from a very nice orthopedic surgeon. I can't get over how nice and caring he was. There's not much to do except wait, and we can get a tissue diagnosis by doing a biopsy on one of the lesions. We don't know if it's cancer or where the cancer may have started, but it doesn't sound good at all, Deb. I am so sorry for you and your family. So about an hour later, she emailed me back. So we are all in shock, I'm heading up there for her test and Dad's infusion. She stated that she's having a CAT scan and a shot. I am assuming they're doing a biopsy that day. Just for clarification, the CAT scan's for her whole body to see where the cancer started. Will we have to wait until she goes to Grand Rapids for results? We are overwhelmed and praying for a miracle. So again, I emailed her back about an hour later. It's my understanding that the CAT scan is only there to see if there are problems anywhere else. I don't think the biopsy will be done that day. I think the biopsy will take place later in Grand Rapids. So that progressed. Thursday, she had her CAT scan. By Friday noon, I had that result in my inbox. We take that for granted. I still take for granted that we can put a mail in a letter and a mail and could be in California in a day or two. I think that's amazing. But for this person, the radiologist have read the X-ray up in Traverse City, to have it faxed down to my office, to be scanned in my chart, for me to be available to have by noon on Friday afternoon. I think that's still pretty remarkable, and I think it's amazing. So I called Sandra. I said, Sandra, the CAT scan doesn't show any sign of cancer in the abdomen or pelvis. You know, that's good news. And she said, oh, thanks for calling. That makes me feel better. That's all it was. So I got another letter from her daughter later that afternoon. She said, thank you for calling Mom and letting her know what the report said about her test. I spent Wednesday and Thursday with them. We made the appointment in Grand Rapids. I'm assuming they'll do a biopsy there. We're continuing to pray that it's not cancer. She said, thanks for contacting her. She felt so much better. Okay? That was it. That's the exchange that took place. So this family, going through tremendous trials, was at least be able to comfort it just a little bit, because a test done on a Thursday was resulted immediately, and the report faxed to me. My staff was able to scan it in so I could see it by Friday midday. Now, maybe someday it won't have to be scanned. It'll be sent directly electronically. Still, I think in one day, that's a pretty good time. Recently, when her husband found out that his cancer had spread, they were down in Florida for the winter. I also received the reports from Florida. I was able to call him and tell him that I just know what's going on. Maybe my calls and communication to this family were in some ways a useless gesture. I mean, I did not improve their health status. I didn't reduce their cost of care. I didn't check off any quality metrics checkboxes. But I don't think it was a worthless gesture. It made me feel good, and it reaffirmed to the family that I care. I think that you can see if you were the patient or the family, you wouldn't have minded receiving these useless gestures, and how simple these calls were comforting to people. I think we forget, again, the simple ways that technology helps us every day. I think the story also points on something else. The speed at which information hits us, and the many ways that we can receive the information. It's one of the hardest things we have to deal with. And this is why I think EMR has changed everything. Everything is now in our inbox, in our face. I get over 100 ADTs a day. Whenever a patient goes to the hospital for a physical therapy appointment, I get a notification. It's like overwhelming almost how much I get. I get emails from patients. I get faxes from patients. I get text messages. The speed at which everything hits us is overwhelming. But I like it because it gives good patient care. And the more efficient we get, the more the patient's demands. Wait a second, you had my test done this morning and it's already 3 o'clock and you don't have my results back to me already? So the better you get, the more they demand, but that's okay. But I think that's why it's hard for me to go back to the old style of practicing medicine, where I was Marcus Welby and I delivered babies and I assisted on surgeries and I did all the hospital work. Because of this work of trying to take care of populations of people and keep them healthy is different than waiting for people to get sick and trying to fix them. Being available and responsive to our patients takes commitment that many physicians do not do because they're not incentivized to do it or they're not willing to do it. But I don't think the importance of this can be overestimated. I mean, I think it's really important, hugely important, that we're responsive to our patients this way. I had a difficult patient. Her name was Sean, and she sent me a MyChart message, a patient portal message, about her upcoming appointment next week. She said she wanted to try the other medication for her chronic pain situation. She's a difficult patient because of the severity of her symptoms, and that nothing I do seems to help her. I do not feel energized after I'm in the room with her for a while. She went online and read about this medication, and when she came in for her visit next week, to my surprise, after expecting a difficult conversation, she said, I don't really want that medication. I read about the side effects and what it could cause. I don't want that. And we tried something else. My experience with people going online and reading about their own health, it's almost entirely a positive experience. They learn about their health, they ask more intelligent questions, and even if they go on to Billy Blob's website and read something that's extremely unusual or not helpful, it opens dialogue and conversation. I really we're not going to prevent our patients going on and looking at their own health status. I don't think we should. In fact, I think we should encourage it. I think we should encourage patients to be more involved in their own health to the best of their ability. Some patients can understand the pathophysiology of their disease. Other people are lucky to know what the green pill is for. But each person is capable of more than we've allowed them in the past. On September 27, 2016, about 3.5 months after Quentin's death, Bill came in to see me. It had been 2 months since I renewed his medication. I honestly can't say I was looking forward to the visit. I mean, what do you say, or how do you help someone who had just lost her son in such a tragic way? I chose not to have my team care assistant me in the room that day. And so I want to read you the visit for that day. This 53-year-old patient presents today for depression and anxiety. Have you had an ER or urgent care clinic visit since, or a hospital admission since seeing last? Yes, I was in the walk-in clinic with a foot infection and vertigo. Order review. Patient is due for as doctor deems necessary. Goals established this visit. None. Advanced directive status. Not received. No known allergies. Current medications. Wellbutrin and Atrovent. Review of systems. Weight loss down 4 pounds. Cardiovascular, chest pain or pressure. Feels tight at times. Shortness of breath, no. Abdominal pain, no. Change in bowel habits, no. Blood in the urine, no. Pain with urination, nope, none of that. History of present illness. This patient's here for depression and anxiety. Patient is here to discuss his continued issues with anxiety and depression. PHQ-9 is 13, indicating moderate depression. His son tragically died in a car accident on June 5th of this year. He's struggling with everything. Energy is poor, sleep's okay, difficult getting up, no suicide ideation. Seeing a counselor and has people to talk to. There's both trauma and grief. The reality of what happened can be suffocating for him. Has vertigo that he's getting therapy for. He's getting postnasal drainage that affects his sleep this time of year. Vitals are good. In general, he has no acute distress. He's healthy appearing. He's well-nourished. He's alert and oriented. He's open about how he feels. Assessment. Number 1, anxiety, depression. Number 2, postnasal drip. Number 3, vertigo. Number 4, body mass index. Don't forget your body mass index to check that box. 23 to 23.9. Discussion. Counseling was given. We'll stay on Wellbutrin for now. He will continue to see his counselor. I think he's grieving very appropriately and calling in support. 40 minutes spent with Bill, 40 minutes spent in counseling. Follow-up as needed. Did you know what the number 1 secret? Wow, there's lights. The number 1 secret to good communication? It has been said that nobody has learned anything by talking. But to be a real good listener, what is vital, most important quality in my book, is that you really have to want to connect with the other person. And of course, listening follows. There are a few things about that record I just read to you that doesn't tell you about that visit. He was my last patient of the day, and I didn't feel rushed. I truly desired to connect with Bill that day. Not just be sympathetic, but empathetic. I'm a parent. What would it feel like for me to lose my son? I closed my computer screen. I sat close, not behind my table, and I leaned in. I asked hard questions, but did not try to fix the situation, but make myself feel better. Too often we say something that will try to make them feel better. It doesn't work. Sometimes you just need to be there. Bill shared many things, and I let him talk. He wasn't sure he could continue his work as a pastor. As he said in the note, the reality of what happened was settling in, and it was suffocating. I don't remember much of what I said. I just knew I said the right things. And that doesn't always happen. He didn't walk out saying that he felt so much better, but the visit ended as it was supposed to. And he left quietly with a follow-up plan. We have a motto in our office that patients won't always remember what you tell them, but they'll always remember how you made them feel. I didn't know at the time how Bill felt, but I sure remember how I felt. I remember crying when I sat down at my desk, overwhelmed with the sheer reality of what we had just discussed. But I also remember feeling that it was strange that I felt energized and not drained. There was no burnout here, and not so much a feeling of professional satisfaction as much as the joy of human interaction. I knew something powerful had happened in that room, something I didn't have total control over, but a healing had taken place. And it wasn't just Bill that was healed in some way. When I called Bill recently and asked him permission to use this story, he knew also something had happened that day in that room. He felt it was the Holy Spirit that had guided our conversation. He remembers me asking him tough questions, but that I wasn't trying to say the right things. He said that in his impaired condition, he felt that God's redemptive power was there. And although it was his story, it wasn't. Before I hung up on the phone, I told Bill, they said, this talk is almost exactly 2 years to the date that Quentin had died. He said when I called him to ask for permission, he was standing in the exact same place that he received the call notifying him of his death. Maybe that's what he meant, that although the story was his, but not his, and that the story needed to be shared. What we do in healthcare can never be fully documented on a computer, on a piece of paper. But I think it's important to remember that it's not supposed to be. I believe true health and well-being lies in the power of relationships. When technology enhances the human connection during our healing and dying journey and doesn't try to replace it, we truly honor all of the patients and families that we serve. When my career is over, what I'll remember most and take the most satisfaction from is the people, the ones that I think I have helped and the ones that I know have helped me. I think the students who spend time with me are surprised at the depth of the relationships I have with my patients. Many of them have commented they are giving primary care a second thought after spending time in our office because they see and they recognize the power of being with people and how good that feels. The problem in healthcare isn't technology, it's us. Hospital systems that focus more on profits than care, organizations who don't want to share their data, physicians who don't want to change and just want to sit back and complain, toxic workplaces, patients not taking care of themselves, lack of focus on the social determinants of health, which are hugely important, and not truly connecting with each other in powerful relationships. It's often said that healthcare is complex and that fixes run into the complexity barrier. But maybe the answer isn't more data and more solutions, but more caring. The big advantage in all of the work we do here, for all of us, no matter where you are and what you do, is that we're also all patients. And we know what it's like or what we want to feel like when we're being taken care of ourselves. So let's expect patients to be responsible for their health, and let's help them be so. Let's be accessible. Let's focus on the workplace culture, which is hugely important. Use teams to do the work. Follow up with patients and be attentive to their needs. Don't leave them hanging. I can't tell how many times I hear patients say, well, he never got back to me. I didn't know what was going on. They didn't know. Focus on the problems, not the solutions. Use the golden rule. Take care of people like you would want to be taken care of. Physicians need to be willing to let go of the past and allow patients to use them the way they need to be used. I mean, physicians are still stuck in that mentality of, we're great because we're physicians. I'm sorry, that doesn't make you great. And love through connecting and caring. Thomas Schwann, in a recent article in JAMA, said the root cause of much dissatisfaction and misery and subsequent loss of well-being amongst physicians today is the loss of the ability and opportunity for physicians to care in the current healthcare system. I think he was wrong about one thing. I think we still have the ability, but it does feel like we're having less opportunity to care because of the many forces seemingly coming between us and our patients. In the movie Evan Almighty, my favorite scene is when God, played by Morgan Freeman, who else could play God, is talking to Evan's wife in the restaurant. She's upset because her husband is building an ark at God's request. God asks her, if someone prays for patience, does he give them patience or the opportunity to be patient? If someone prays for courage, does he give them courage or the opportunity to be courageous? And if someone prays for them to be closer to their family, which she had earlier in the movie, does God zap them with warm, fuzzy feelings, or does he give them the opportunity to love each other? What I want most from health information technology is to enhance my opportunity to care. I think most of us still have the ability. There are good people doing wonderful things in Michigan, trying to connect us in important, meaningful ways. But does HIT really make my job easier and relieve my burden? Not really. It doesn't. But is it better for my patients? Absolutely. And that's why it's worth perfecting and willing to go down that road, because it is better care for our patients. Maybe one of the questions that should be asked of any HIT in Michigan is, does it give an increased opportunity to care? Because for me, that's the really value of healthcare. What I didn't know about Ring of Fire, that song, it's about the transformative power of love. That's what that song's about. Kind of ironic, you think about it, when we're talking about fire technology. And the bottom line is, for most of us, is we have a chance for meaningful work with people who care. And to me, health care, it's the care that's all about. Thank you very much. Questions? If anybody has any questions, and I'm not going to sing anymore, I promise.
Thank you so much. I just humbled to hear you speak. You shared about the 3 A's of being a good physician, and you said that you were adding 2 more. And if you just reshare what those 2 are, you said
Allow and assist. Yeah. So you have to be available. You have to be affable. You have to have ability, and you have to allow them to take care of themselves, and you have to assist.
amazing. Thank you so much.
Yes. Yeah.
Oh, thank you. Thanks so much for the talk. I really appreciate it. My name's Carla Smith. I'm with HIMSS. And I was interested in what you said earlier in your presentation about how you now have an LPN and a medical assistant that join you
Yes.
in your patient
Yes.
visits.
Yes.
And that you think that that's a real benefit
Yes.
for patient care. Fantastic. I'm curious about how you've made the money work. Because, of course, there's compensation
Yes.
aligned with those folks. So has the pool of resources gotten bigger, or are you dividing the pie into smaller pieces?
It's a great question. The 2 ways we make up for first of all, my employer was willing to go down this road and consider this. But honestly, they're big, so he'll see more patients this way. He'll spend less time documenting, he'll see more patients. Therefore, the more patients he sees, the more money he'll bring in. I probably see 1 or 2 more patients a day because of this, although obviously the promise of EMR is to increase the amount of patients that we can see because we're more efficient hasn't come through, and it won't come through because there's just too much to do. But not only do I see 1 or 2 more patients a day, which pays for the assistant itself, my upcode, I don't upcode, but I code more appropriately. I'm documenting my level 4s better now. And so my level 4s went from like 15 to 20% of my billings to 50 or 60% of my billings. Not because I'm doing more work, because I'm documenting the work better because of them. So in those 2 ways, the team care system pays for itself.
Oh, sure. My name is Bill Serlin. I'm from Blue Cross Blue Shield. I'm just wondering, with the rise of telemedicine, do you see more of a disconnect between your patients?
Yeah, it's a great question. It's a great question. You know, so I think about it. Okay, telemedicine, retail clinics, artificial intelligence. Are we focusing on the solutions again and not the problems? Do patients really want this technology? Now, I think Fitbits and any apps that encourage people to be healthy or take care of themselves or motivate them to be healthy are fantastic. But I think there's a real place for all that, and there's a real place for telemedicine, especially in specialty-deprived areas where you can do it over the phone. But they say most of the communication is nonverbal. How do you communicate with somebody, technology-wise, if most communication is nonverbal? So I think there's a huge place for it, but I think to think that since primary care is fading and nobody wants to go into it because they don't get paid enough and there's more burdens and the technology is getting in the way, so let's just get more technology to fix the problem, I don't think it makes sense. And I could be Mr. Old Fuddy-Duddy and old-fashioned because I'm used to the old ways of doing things, but I don't think so. I think anybody who has a caring relationship with their physician knows what that feels like, and I don't think you can totally get rid of that and wash it away. So I think those are useful adjuncts, and they should be pursued, but I don't think she'd be held out there as the answer or the solution to our problem.
You had mentioned that you really like the ADT alerts and all that information that comes in.
Yeah.
Can you describe who actually receives those ADT alerts and the CCDs and how that gets into you mentioned you had an Epic system.
Yes.
And I know you use Care Anywhere. That gets you to other Epic
Yes.
systems. But
only people have other Epic systems.
right. So I'm interested in how you get the information from the eClinicals,
Yeah.
the Cerners, the McKessons, all those other ones into your Epic system.
We use the patient ping. Patient ping alerts us of most of the discharges that happen to us. And we have a care manager in our office. We've had now one for 6 years, and it's her job to go through the discharges and to see which ones she needs to call and which ones she needs to fix. Frankly, we don't go into the ADTs as much as we could. We don't call everybody who's been in the emergency room and ask them why they went to the emergency room or how they're doing or what's going on, because we just don't have the time or the staff at this point and haven't put systems in place to deal with that. But most of the ADTs I still get across my screen. I see them from the Epic end of it. But the ones that aren't Epic, they go to our care manager, and she trolls the list every day and identifies who needs to be addressed and who doesn't. But we still miss patients and fall through the crack. We still don't have enough time spent on reaching out to those people. And so we're working on it, still trying to figure out. It's all about workflow. You know, this opiate thing, which I think is important, But for me to have to run a MAPS on every month on every refill I do, it's almost like the last straw on the camel's back almost again. It's like, okay, it's just more work that's really necessary that it doesn't really serve that great a purpose. Now, I think MAPS are hugely important, and I think we need to do them. But there's got to be a way to do it so it's not prohibitive. So we are trying to figure out the workflow and how we handle all of that. But the ones that don't go through Epic, we get through the patient ping, which I think is very useful technology.
Hi, Dr. Stefanik, Dara Barrera from the Michigan State Medical
There you
Society.
are. Okay.
So we know that the EHR is one of the leading reasons for physician burnout, and we hear this a lot. And so I'm thinking of your peers who may not be as forward-thinking as you are. I know we've had this discussion often. What one or two things could other small practices do with their EHR to help them become a higher utilizer so that they are more efficient, so that they can start to use the technology to give better care as you speak, as opposed to, having it be a huge burden? Is there something that they can start with to move down that path?
Very, very good question. I think first of all is scribe concept, is the team care concept. If they don't have someone helping them use the MR in that way, I think they should. I think there are organizations that they belong to. Most of the physicians are in POs or organized systems of care across the country. There's resources there that they can use to tap into that and help. But I also think I don't know how you change the attitude. I don't know how you make them realize that things are different. And just sitting around complaining about how they used to be is not going to really get you to where you need to be. And I think just spreading the message. Again, I think every physician went into medicine because they wanted to care about people. At least most did. And somewhere along the line, they've lost that and they've separated that. They need to be reinvigorated with the joy of it. For me, making the patient more responsible for their health is totally freeing and it's fun. That's probably the thing I could describe most about my practice. It's fun when I really have these engagements with the patients and have them step up and be more responsible. It takes the burden off me to feel like I'm responsible for taking care of them. So physicians who are burned out and tired and don't want to do it anymore, I guess I would say, focus more on the patient and let them be more in charge of their health. Make sure your office workplace, you're supported, and make sure that you don't, dribble that bad attitude down to your staff, because then it goes right to the patients. I would put my front desk staff against anybody in the state as far as how welcoming and accommodating that, because we recognize how important that is. And we don't have an automated line system. You talk to a person. So I think it's just going back to that personal human touch, reminding them of what and why they went into medicine to begin with. But the burnout's real, the stress is real, the financial pressures are real, and how, the final answer, I don't know if I have it, except, I think the scribes has been a huge, huge help for me.
Hi, Tom Simmer from Blue Cross. First, I won't tell you that was an excellent talk, because that would be unnecessary, because everybody here heard your talk and knows it was excellent. But my question really is related to using technology to help us understand what's going on in the home. And I'm wondering if you could comment on that. You did mention social determinants.
Yes.
And I have heard people describe how the insights that they learned in the home did affect their perspective and their interactions with the patient. I'm just wondering if you had any insights on that you can share.
That's a great question, Tom. The way I do it now is the way I've done everything, is kind of by the seat of my pants. I know my people. I ask them questions about them and their family. But we are starting to collect data on the social determinants of health, and we have not yet taken to the next step. Now, I know organizations have. I just talked to Ed Worthington from up in Northern Physicians just the other day. They have, for a while now, collected social determinants of health data, and they have it so that automatic referrals then generated to the public health department or to 211 or to necessary services. So the work's being done, and I think that's the way you do it. You start first of all, and I'll share this story. At one of my board meetings, and these are physicians on the board of our organized system of care. I told them I went to a social determinants of health conference, and they both looked at me and they said, "God, I'd rather go to the dentist than do that." Yeah, seriously, if it's 70% of what our health is for our patients, and they'd rather not learn about it or how important it is, I think there's still that barrier. So the first thing is getting your office on board how important those are for our patients. I don't think you can deny that it is, that data says it is, and then find ways to collect information and then connect that to resources in the community. So I mean, we're working on that. We haven't fully broached that subject yet, but that's a really good question, and it's important work, and it's happening. This talk came at a really interesting time for me because I've recently accepted another position. For 27 years, I've been doing the same thing with the same patients. My nurse, Amy, of 25 years, is still mad at me, and she hardly talks to me. My staff gives me the cold shoulder most days, but they understand why I'm doing it. When I tell my patients, and I've started to do that, it's interesting, and I oftentimes when I'm with students, I'll ask patients, what are you looking for in a doctor? What's the most important thing? I almost never get, well, I want somebody who's really smart, because they expect us to know what we're doing. They say, I want someone who listens to me. I want someone who's available to me. I want someone who makes me laugh. I want someone who's personable with me. That's what I hear. It's not, geez, doc, thank you for prescribing my medication, although they do like the fact that I'm available to them in so many different ways. And being more available hasn't been a burden. It's been more of a joy than anything else. So as I think about the 20 years I've done this, and the first reaction I get from patients when I tell them, the first reaction is, wow, what an exciting opportunity for you. I'm happy for you. And the second most common is they start crying. And that's the power of the relationship that we've had over these years. And so I'm venturing onto something I think is going to be really exciting for me, and I'm going to continue the work that I love and making patients more responsible. But I'm just blessed for the 27 years I've had with my patients, and we can't lose that in healthcare. And when we are losing it, and we've got to focus on it and make it realize why it's so important. Thank you very much.